If your doctor recommended a steroid shot for your heel pain, I need you to watch this before you say yes. I gave those shots for years. Now I've stopped. And the reason why is something most doctors won't tell you. In the next few minutes, I'll show you what a steroid shot actually does to your tendon over time, why most heel pain patients never find out until it's too late, and what I used instead to fix the problem rather than masking it. You've been dealing with heel pain long enough that's changing how you move, what you wear, and what you can do. You've tried rest. You've tried stretching. Maybe you've already had one shot and felt better for a few weeks before the pain came right back. So now the recommendation is another one, and you're starting to wonder if this is just how it goes. After 25 years treating foot and ankle conditions and performing over 25,000 procedures, I started seeing a pattern I couldn't ignore. I'm going to walk you through the 3 reasons steroid shots keep failing heel pain patients, what they're actually doing to your tissue over time, and what the approach looks like to get people better for real. Point 1. Steroid shots don't heal anything. They only mute the signal. Your doctor recommended a cortisone shot, and it made sense. The heel hurts because it's inflamed. The shot reduces inflammation. Pain goes down. Problem solved. That's what most patients are told. And honestly, that's what most doctors believe they're delivering. This isn't bad medicine from bad doctors. Inflammation reduction is a real goal. And for a lot of conditions, steroids do exactly what they're supposed to. The problem is what happens in the heel specifically. The plantar fascia, that thick band of tissue running along the bottom of your foot, is not just inflamed. It's under load. It's being pulled, stressed, and strained with every step you take. A steroid shot quiets the pain signal, but it does nothing about the mechanical stress causing it. So the patient feels better, walks normally again, loads the tissue the same way that they used to do it before, and within weeks or months, the inflammation is back. Worse, repeated steroid injections have been shown to weaken the tissue itself over time. You're not healing the heel, you're just numbing it while it gets worse underneath. A steroid shot doesn't fix your heel. It just turns off the alarm while the house is still on fire. The goal isn't to reduce inflammation. The goal is to give the tissue what it needs to actually repair itself. I see this pattern constantly. Patients come in who've had 2, 3, sometimes 4 rounds of cortisone. Each time they got relief, each time it wore off faster. By the time they reach me, the fascia is in worse shape than when they started, and now they're working around the damage the shots left behind, not just the original injury. When you stop chasing the pain signal and start addressing the tissue, the relief you get is real, not temporary fix that closes in 6 weeks. But the inflammation story is only part of what's wrong with the standard approach. The second problem is more serious, and it involves the tendon right behind your heel. Point 2. Steroid shots near the Achilles are directly linked to tendon rupture. If the pain is in the back of the heel or up in the Achilles area, the shot goes there. The standard protocol. Most patients don't think twice about this because it came from a doctor, and doctors don't recommend things that can cause harm. The practitioners giving these shots are not being reckless. This has been common practice for decades, and it does provide short-term relief. The problem is that research connecting steroid injections to Achilles ruptures has been building for years, and it still hasn't changed the standard recommendation for most patients. Here's what the research shows. Corticosteroid injections near a tendon can break down the collagen fibers that give the tendon its strength. The tendon feels fine because the pain is gone, but structurally it's weaker. For an active person, a weekend runner, or someone who plays tennis or basketball, the weekend tendon is now under full athletic load, and in some of those patients, it can rupture. A ruptured Achilles means surgery, months of recovery, and a tendon that will never quite be the same. The shot that was supposed to fix your heel could put you in a surgical boot for 6 months. Before an injection goes near the Achilles, the right question is not, will this reduce the pain? It's, will this protect the tendon or weaken it? This is part of why I stopped. I wasn't seeing ruptures in every patient who got shots, but I was seeing enough of them where patients who did everything right, followed the protocol, got the injection, went back to their activity, and then one morning the tendon went pop. And every time I look back at the chart, there was a steroid injection in the recent history. Choosing the right injection, one that supports tendon repair rather than breaking it down, means you can address the pain without creating a secondary injury. That's far more serious than the one that started it. So if steroid shots aren't the answer, what is. That's where the third piece comes in, and that's where the approach has completely changed for me in the last decade. If you're finding this useful and you're dealing with heel pain that hasn't responded to standard treatments, make sure to subscribe. Next week, I'm going to walk through specific questions you should ask before any injection goes near your heel or Achilles. Point 3. Figure out whether your heel pain is a fascia problem, a nerve problem, or a tendon problem, because treatment is completely different for each. You've probably been told you have plantar fasciitis and left it at that. But here's what most patients don't realize. Heel pain is not one condition. It's a location, and 3 completely different problems can cause pain in the exact same spot. Before any treatment makes sense, you need to know which of these types of heel pain you actually have, because the shot that helps one type can make another type significantly worse. Diagnostic questions you should ask. Does your pain hit hardest when you first step in the morning or right on the bottom of the heel? That points more towards plantar fascia. Is there pain more in the back of the heel near where the tendon attaches and gets better after activity rather than first thing in the morning? That points more towards Achilles tendon issues. Do you have burning, tingling, or numbness along the heel? That points towards a nerve entrapment, which is frequently misdiagnosed as plantar fasciitis. If your pain matches the first pattern and only the first, conservative regenerative approach to the fascia makes sense. If it matches the second, anything that weakens the Achilles is off the table. If it matches the third, treating the fascia at all is the wrong target, and every shot, stretch, and insert aimed at this is aimed at the wrong problem. Once you know which type of problem you're dealing with, the treatment picture gets much clearer. Here's what the right approach actually looks like. Match the treatment to the tissue, not just the location of the pain. Stop treating heel pain as a single diagnosis and start demanding a treatment that targets specific structures that actually are damaged. If you've already done multiple rounds of treatment without lasting results, the most likely explanation is not that your body isn't healing. It's that the treatment was aimed at the wrong target. Another round of the same thing will produce the same result. The patients who get better and stay better are almost always the ones where we've done the diagnostics work first. Ultrasound imaging in the office takes minutes and shows us exactly which structure is involved. When we know that, the treatment becomes obvious. When we skip that step, we're guessing. Stop accepting a heel pain diagnosis and a corresponding injection without knowing which specific structure is being treated and why that injection is appropriate for that structure. Ask your provider to show you an imaging where the damage is and explain exactly why the proposed treatment addresses that structure. If they can't do that in plain language, you need a second opinion before you agree with anything. And once you have clarity, there's actually one thing that you can start doing tonight that begins to address the root cause, not the pain, the actual tissue breakdown underneath your heel and why it's occurring. Start loading the tissue the right way, because the fascia heals under the right kind of stress, not rest. The plantar fascia is a load-bearing structure. It responds to mechanical stress, meaning it actually needs the right kind of movement to heal. Total rest weakens it further. The wrong movement inflames it. But a specific controlled load protocol done consistently gives the tissue the right signal it needs to rebuild collagen and restore strength. Think of it like a muscle after an injury. If you never use it, it atrophies. If you overuse it, it tears again. But if you load it carefully and progressively, it comes back stronger. The fascia works the same way. It just needs you to know the difference between the load that heals and the load that hurts. Before bed tonight, do this sequence seated on the edge of a chair with bare feet flat on the floor. Place a small rolled towel or water bottle under the arch of the affected foot. Slowly roll the foot over it, pressing gently into the arch, and hold for 3 seconds. Do this 10 times. The pressure should feel like a stretch, never a sharp pain. After the rolls, stand up slowly and take 3 or 4 deliberate, slow steps before putting full weight on the foot. This is not a cure. It's a starting signal to the tissue that load is coming and it needs to prepare. Patients who do this consistently in the early morning and before bed report that the first steps in the morning pain being far better after 2 weeks. Steroid shots become the default for heel pain because they work in the short term and they're easy to do. But short-term relief that creates long-term tissue damage is not the treatment. After 25 years, the patients I see who actually get better are the ones who stopped masking the pain and started giving the tissue what it needs to repair. That's what this approach is built around. My suggestion is that you start doing load-bearing exercises, and if you still are having pain, you may want to consider regenerative treatments. Shockwave therapy, platelet-rich plasma, stem cell injection, and even minimally invasive tissue debridements can help to heal the fascia without weakening it. This tissue treatment actually helps to rebuild collagen and rebuild the thickness and structure of the fascia and can be very helpful to heal the tissue. If you're having problems, maybe what you should consider is a further workup and treatment. If your heel pain has been labeled plantar fasciitis and nothing has worked, watch the video linked below. It covers the one misdiagnosis that keeps thousands of patients stuck in the wrong treatment for years and how to tell whether it applies to you. Link is in the description and on the screen right now.